Okay, great. Hi, everybody. My name is Zara. I am an occupational therapist and I have an undergrad in psychology and neuroscience. And today I want to talk to you about pain. So, this is part one of a two-part series. Next time, we're going to be talking about self-management strategies. This time, we're going to be talking about understanding pain science, and then a little bit about how to move with pain. So, you will have some things to focus on over the next little while. I will say before we get into this is a lot of information. This is very science heavy. If you need to take breaks, feel free to do so. And this will be recorded and put up on Dr. Arsenault's YouTube page. So if you need breaks, come back to it later, because this will be a lot of information to digest all at once. So take care of yourself. A little bit about me. So I'm, like I said, an occupational therapist. And I've spent the last 4 years working with people in pain, so a lot of people with chronic pain. But also, when I was a kid, about 13, I fell off a horse and severely injured my pelvis and was in pain myself for about 10 years and was able to get over this pain and to manage it very well with the education that I'm going to give you today. So the education that I am going to give you today is exactly what helped me get out of my pain spiral, so to speak, and also the pain spiral of hundreds of my patients now. So I know that this stuff works personally and from the research. Everything that I'm presenting to you today is from, looking into a lot of books and research papers around pain and what the leading scientists in the world think of when they're talking about pain. And that's me on the right, climbing and hiking mountains and doing all the things that I love to do despite, having that injury. Now I can do anything I need to with my hip, which is awesome. So before we get into talking about relating to our pain differently, it is important that we are paying attention to things that could be dangerous. So we're going to be talking about chronic pain and how that affects us, but we also want to be mindful if there's anything sudden or unexplained. So I do want you to chat to your doctor if you have sudden redness, swelling, or burns. Some people with CPRS will have redness or swelling, but that's something you're probably used to within the diagnosis. But otherwise, if there's sudden major increase in the severity of your symptoms, loss of muscle control, bladder control, unexplained weight loss, or a sudden lack of balance and coordination, or like just a very big increase in your symptoms, then definitely talk to a doctor and don't just take this education and try to apply this education to that, because these could be things that are more serious. So let's talk about what chronic pain is anyways. What does it mean? Chronic pain or persistent symptoms, persistent pain, is defined as pain that lasts more than 3 months. And it's usually unexplained, but we can see chronic pain for things like arthritis or, pinched nerves or whiplash injuries or fibromyalgia. These are all types of chronic pain, but the general thing that they have in common is that it lasts for more than 3 months. According to Stats Canada, there's 7.63 million people that experience some kind of chronic pain in Canada. That's a lot. That's a huge portion of our population. So if you're experiencing pain, you're certainly not alone, and that's important to know. What we do know about pain is that medications, massage, and passive techniques, they provide temporary relief, but it's not necessarily sustainable, right? You might get a massage and feel good for a week or 2 weeks, but it doesn't really feel like it's actually sustainable relief. So it's important to consider education and self-management strategies are actually the most effective kind of treatment. So you're probably, we're going to be going through this education today and you're going to be like, why are you giving me all this education about pain and how it works and like the neuroscience of it? Like, I just want to know how to fix it. I'm telling you right now that this information is how to address your pain. So understanding pain and understanding how it works in your nervous system, that is actually going to help you manage pain in the long run. So that's something to be aware of and to note. And also, it's really important to empower you. So what can happen when we're in pain is we can get into this pattern of what we call an external locus of control. And what external locus of control means is that we believe that someone else needs to fix us. So we believe that there is some silver bullet out there that if we can just find that one thing, it's going to fix us, it's going to change us. And if we can just get a doctor to do the right thing to our bodies, then maybe we'll change our pain. Yes, there are treatments out there that are super helpful. There are things like trigger point injections and Botox and prolotherapy and lots of things that are actually really helpful for pain. But we also need to have an internal locus of control, meaning that we can do something about our own pain. And hopefully by the end of today, and especially by the end of the second presentation that we do, I want to empower you to feel like you have strategies that you can manage your pain and you can actually make changes in your own body, because I think that's really important. So, big question, what is pain? So we want to think about this for a second and kind of on to yourself, think about, what does it mean? What does pain mean? How is it produced? Why do we even have it? Like, what is the point of pain? And oftentimes when I ask this question, what people will say is that pain means something is wrong. That's a very common correlation, because that's sort of like what we think of in our society as pain means something is wrong. And if I'm in a lot of pain, something's really wrong, right? But what I want to do is kind of challenge that perception that pain means something is wrong. As I'm challenging this perception, I'm going to say this like 100 times today, because it's really important to me that you understand this. Your pain is real and your pain is valid, and it's not in your head. And again, I'm probably going to say this like 100 times, because every time I give this education, people tend to say, why are you telling me that my pain is in my head? And I'm not. I want to make that super clear, because when I first received this education, I got really up in arms and really upset. And I felt like the people giving me the education were telling me that my pain wasn't real. So as we go through this, it's important for me to say over and over again, no matter what I say throughout this whole presentation, your pain is real and it's valid. So let's talk about what is pain, though. So pain, the way that I like to view it, and the way that they like to view it in pain science, is that it's an alarm system. So it can warn you when you're approaching damage, when you have been damaged, or you're in a similar situation where you've experienced pain before. Pain can come from a physical problem, but also from emotional or situational. So if I'm in pain because I broke my pinky finger, I'm not really in pain because the finger is broken. I'm in pain because my body is trying to protect it from further damage, which is a subtle distinction, but it's an important one. Basically, it's a little alarm system saying, oh, like, don't do more. Don't do more than that, because we want to make sure that you are protected. So pain is protection. That's a really important thing to know, is that it's protection, but it doesn't necessarily mean that something is wrong, because the pain system doesn't always act as we expect it to. So sometimes people experience very little pain despite a significant injury. So if you think about, a soldier in a life or death situation, or you think about an athlete in an intense competition, sometimes people have a very significant injury happening, but no pain. Sometimes people have the exact same looking spine on an MRI or an X-ray, and one person is in debilitating pain and another person is not in pain at all. So why would that happen, right? And we're going to explore why that is. And sometimes there's pain without cause, right? So sometimes if we think about, for example, phantom limb syndrome, this is where somebody's literally had a limb amputated. So let's say it's their right arm, but they're having extreme pain in their right hand, the right hand that doesn't exist anymore, their right hand that's not even a part of their body anymore, right? So it's a weird system, right? It doesn't always act as we expect it to. So more pain doesn't always equal more tissue damage. And we're going to kind of get into this a little bit more with this example. So this is a construction worker in the 90s, and he jumped off of a ladder and got this nail through his boot. And if you've had pain education before, you might have heard this story. But as the story goes, he was in excruciating pain. He was screaming. They called him an ambulance. He said that he reported that every single bump in that ambulance felt horrible and excruciating. And he went to the ER and they gave him some pain medication, and then they started to take off his boot. And when they took off his boot, they realized that the nail hadn't gone through his foot at all. So he didn't have any physical injury, but he was in a ton of pain. And so this interesting question comes up, like, is his pain real, right? Did he need those medications? And the way that I look at this is like, yes, it's completely real because he was in pain. And when somebody says they're in pain, that's real because pain is produced in our nervous systems. Pain is not produced in the area of pain. So, like, for example, if I'm having low back pain, it's not because there's like a pain receptor in my low back that is alerting the rest of my body that I'm in pain. It's because there's these little things called nociceptors, and they detect chemical changes and pressure and heat. And they send that information up to my brain, and my brain will decide whether it needs to produce pain or not. My nervous system is going to decide whether it needs to produce pain or not. Because the nervous system is involved in producing pain, sometimes even if those nociceptors aren't sending signals up to the brain, if we have enough information that says that we're in danger, like this guy, he has a literal nail through his boot and his brain is processing that as I'm in a lot of danger right now, then we create more protection, right? Remember how we said pain is protection? So this is a really interesting example of how our brains can create this protection when we feel like we're in danger. And there's this like alternate sort of thing that happened with another construction worker and another nail gun, where he was using a nail gun and it unexpectedly discharged and it clocked him in the face. And he had a bit of a toothache, but he kept working and he kept eating and he kept hanging out with friends and doing his normal days for 6 days. So for 6 days, he was hanging out doing normal things. Then he went to the dentist for this mild toothache, and the dentist said, when they did the x-ray, you have a 4-inch nail embedded in your head, embedded in your like jaw. And the interesting thing here is that his body didn't think that he needed protection, so it didn't create pain. He didn't have any signals, right? He couldn't see the nail in his face. He just noticed a little bit of bruise and had a little bit of a toothache. So his body was like, meh, we don't need to protect you. It's fine. It wasn't looking for those signals of danger. And this is going to become really important as we continue to explain this. So like we're talking about those nociceptors, right? We don't have pain receptors. So if that's something we believed before, we want to just get the idea out of our head that there's pain receptors at all, because there isn't. There's nociceptors, and they detect chemical changes, pressure, and heat. Now, when we've been in pain for a long time, so when you've been in pain for 3 or more months, those nociceptors actually can become more sensitive. So what does that mean? That means that lighter pressure, lighter heat, and cold changes can actually stimulate those nerves to send information up to the brain saying that we need protection. This is called central sensitization. So this is a sensitization of our nerves and our nervous system that sends a signal to our brain, our nervous system, that we are in danger and we need to protect ourselves, so we need to create pain. And this relates to chronic pain because pretty much anyone who's had pain for more than 3 months is going to have some kind of sensitization, even if it's arthritis, right? Even if we have this underlying joint condition, we're still going to have the sensitization on top of it that is creating this increased response to pain. And this is another reason why it's so important to, again, to validate that it's not in your head, because how could it be in your head if your nerves are literally changing, right? You're having an actual neurological change in your body that's making you respond to pain more. Now, the interesting thing about neurological changes is that we have neuroplasticity, right? Our nerves are able to change. That's how they're able to become more sensitive to pain. But neuroplasticity works both ways. So while if you have an underlying condition, like you have inflammation, you have maybe a pinched nerve or something like that, or, maybe even you have a tumor that's pressing on something, those are underlying conditions that that might not be able to be fixed right away, but we can definitely work on the sensitization, and we can definitely work on reducing the alarm so that we don't have as much pain. Does it mean that the pain is going to go away? No, not completely, but we might go from like an 8 out of 10 pain to like a 4 out of 10 if we can manage the sensitization piece. Again, your pain is real. It's valid. It is a nervous system change, and it's really important to recognize that just because pain is produced in our nervous systems, it doesn't mean that we're making it up or that we are just, it's not a conscious decision. It's the same thing as like, I don't decide what something smells like, right? But my brain is interpreting that a rose is a rose and it smells like a rose, right? But it's the same thing with pain. It's like my brain is interpreting signals and deciding what it's going to do. It's the same with any sensation. So in the same way that you don't make up your smell or what you're seeing, you don't make up your pain. But it's important to understand why some people experience this long-lasting pain and others seem to be symptom-free, right? Some people get an injury and then they recover fine. So let's talk about that a bit. Why do people have persistent pain? So there are some mental connections to persistent pain, just like there are mental connections to everything, right? If we're more stressed or we have a lot of depression and we have anxiety, we have significant trauma, there might be more pain, right? There might be a lot of different symptoms. These are heavily taxing on our physiological system. So of course that can create more symptoms in general. Does everyone that I treat with chronic pain have trauma? No, definitely not. And that's just one piece of the puzzle that could be why some people have persistent pain. There's also personality. So we do find that people who are self-critical perfectionists or type A personalities tend to have more pain. Why? We don't really know. That's just something that they found in the literature that's interesting. And we think about physically, we know that bones, muscles, nerves, ligaments, they all take about 6 to 8 weeks to heal, unless something is completely severed. So let's say a nerve is completely severed, which grows back at about 1 millimeter per month. Then it's going to take about 6 to 8 weeks to heal. So after 6 to 8 weeks, all these things are healed. They're feeling better, right? Cancer, arthritis, nerve damage, those can cause chronic pain. But like I said earlier, there's usually a component of sensitization involved with that. Other things that can cause persistent pain that are physical, that are very, very physical, weaker supporting muscles. So after an injury, our muscles may become weak in that area. We see this a lot with whiplash, and deep neck flexors become weak. Compensatory movements. So when you've been in pain for a long time, like for me with my hip, I was really using a lot of my other leg to support my body weight. And so things became a little unbalanced. And part of my retraining was not just, learning about pain and figuring out how to manage pain. It was also retraining so that I moved in a way that was normal. And I moved in a way that made sense for the activities that I was doing. Tension in muscles, of course. If we're stressed, we're more tense, right? Or we might just like our body might feel like we really need to protect these areas. So we might have more tension in general. And then inflammation too. That's a huge thing that can cause pain. It can cause things like arthritis and fibromyalgia. There's a huge inflammatory component to that as well. So there's a lot of different things that can lead to us having more pain. So the main points from this: hurt doesn't equal harm. So just because we're in a lot of pain doesn't mean there's something horribly wrong. And most of the time, things have healed within 6 to 8 weeks after an injury. So usually there isn't something horribly wrong happening in the body. And constantly trying to seek what is wrong after you've done the basic things like gotten yourself an x-ray if your doctor recommends that, or an MRI or something. We don't want to keep seeking like, what's wrong with me? What's wrong with me? I got to fix it. I got to make it better. Like that can actually just influence that cycle of pain. And pain is an alarm system. It's not an accurate indicator of tissue damage. So we talked about how it becomes more sensitive, and we've all had a fire alarm that goes off when we're making toast. It doesn't mean that there's no signal there. It's not the fire alarm just going off for no reason. There's something happening that's causing that alarm to go off, but it's not a fire, right? It's not something that needs protection. So we have to start asking ourselves, is my body in pain in such a way that it needs protection, that it needs me to not move and not kind of move through these things? This is a really nice quote by Viktor Frankl, who's a Holocaust survivor. And he says, between stimulus and response, there's a space. In that space is our power to choose our response, and in our response lies our growth and freedom. So between the stimulus, between feeling that normal sort of reaction to pain, or the normal like stimulus of pain, like we feel a little twinge in our shoulder and we have shoulder pain, and how we respond to it, there's this tiny little space. And what we want to start to do is change how we respond to the pain. So we're going to slowly start changing how we interact with the pain and respond to it. And that can actually decrease the sensitivity in the nervous system. So 2 practical strategies so far. And this is really important because what happens when I've given this education, and I've given it to so many people, I've heard a lot of feedback. And what happens when I give this education is that people say, oh, you're telling me that I should just ignore it, that I should just pretend it doesn't exist, and then it'll get better. No, absolutely not. We don't want to ignore anything. If we ignore any of our emotions or our pain, it's like shoving a beach ball down. It's just going to blow up in our face. It's not a good thing to ignore. But what we want to do is what I call especially in like some of the trauma work that I do with people, what I call it is opening the aperture. So right now our aperture is very small. We have a little pinhole that is focused a lot on the pain. So it's possible that a lot of our attention on the daily is focused on our symptoms, whether it's pain or fatigue or any number of symptoms. We're really just kind of get absorbed with the symptoms. And when the pain is there, it's like all we're focusing on. But in any given moment, there is 1,000 things we could focus on, right? There are many, many other sensations happening. From the tips of my fingers all the way down to my toes, there's so many sensations happening in my body that aren't pain, right? And then externally, like so many things I'm seeing and so many things I could smell and so many things I could feel that aren't pain. So what we want to do is not be like, oh, it's fine, I'm not in pain, I'm all good. No, we want to say, okay, when I have pain, first of all, I'm just going to acknowledge that I'm safe. So I'm going to say I'm safe. There's not something wrong. Nothing in my body needs this much protection right now, right? I know that my body is healed. I know I'm not in danger, right? And I don't need as much protection. Just kind of that self-talk can be really helpful for pain. And then redirecting your attention to what's right in front of you. So opening up that aperture, noticing other things that are around you. You know, what do your ears feel like? What does your nose feel like? What do your toes feel like? Just noticing anything that might be neutral or pleasant is going to really start developing the neuroplasticity of attention. So what we pay attention to, our brain will give us more capacity to pay attention to that even more. So if I'm paying attention to my pain all the time, that's going to increase that sensitivity because the nociceptors and our nerve cells in our brain, our neurons are going to say, oh, she's really, really interested in that pain. Let's give her more resources to focus on it more, right? But if my brain is like, oh, she's actually really interested in her experiences of things that are pleasant or neutral, then my brain will give me more neural pathways to focus on those things. So this is where the concept of pendulation can come in. We've talked about this in other lectures, but we want to notice the pain, try to observe it objectively, and then notice somewhere that's neutral or pleasant, and then switch between the two. So like, let's say I had pain in my hip. I'm noticing, okay, there's pain in my hip. I can feel it. And then I'm saying, okay, what does my nose feel like right now? What does my neck feel like? What does it feel like to be sitting on a chair? Like noticing something that's neutral or pleasant and switching between the two. And notice how this is not ignoring your pain at all. We're not ignoring it because we're acknowledging it, and then we're just acknowledging something else that's neutral or pleasant. So this brings us to the Twin Peaks model. And sorry, there's something in my throat, so I'm just going to take water. In the Twin Peaks model, the idea here is that we have protection from pain before tissue tolerance. So if you want right now, you can take your finger and bend it backwards towards the back of your hand. And as you do this, there's going to be a certain moment where your body says, don't go any further. This is protection from pain. So there's a moment where it hurts a little bit and your body says, don't go any further. But if you release your finger, it's fine, right? I'm not going to know tomorrow that I did that. I'm not going to feel that tomorrow because I have had this protection from pain before my tissue tolerance. So my protection from pain came before I did any damage. this is what I'm saying. When you break something, you're not in pain because it's broken. You're in pain because your body's trying to protect you from not breaking it again. So after an injury, you have a lowered protection from pain. So if I did break my finger, then even touching my finger slightly is going to cause a lot of pain, but I'm very far away from re-injuring it, right? Slightly touching my finger when it's broken is probably not going to injure it. Moving it around, maybe, but just a little touch isn't, but that still hurts a lot, right? So after an injury, we have this lowered protection by pain, and our tissue tolerance is a little bit lower. But what happens over time is that the tissue tolerance goes back to normal, and our protection from pain, if we're in chronic pain, stays low, right? So that's the sensitivity we were talking about before, where those nociceptors are more susceptible to sending signals like they have to protect you. And we actually see changes in the brain too. So this is what's called the homunculus, or the somatosensory map. And we see changes where, for example, you can see here how the lips and the fingers are the biggest part of this map. So this is your brain. And on your brain is this map of sensations. And if I were to poke you in your brain on this area, for example, you would feel a sensation in your lip. So this is a map that represents the sensations in our body. Now our fingers are big and our lips are big. Why? Because we have more sensation in those parts of our body. But you notice places that people have a lot of pain, joints, so shoulders, back, knees, these are actually kind of small in this somatosensory map. But when we're in chronic pain, these areas of representation in the brain actually get bigger. It's the same thing if we were like a violinist, then the area for the fingers would get larger in the brain too, because we can feel more with our fingers. So basically, it takes up more space in the brain, and that's part of the neuroplasticity of attention, right? We've been paying attention to that pain more, and then our brain neuroplastically changes to give us more resources, literally more space in your brain to pay attention to it more. This is another example of how your pain is completely valid and real, because your brain has literally reorganized to feel that pain more. That's not something you consciously chose, right? And we didn't consciously choose the layout of this map in the first place. So that's another way in which it's very valid and very real. And also another way in which there's hope, because these things can change, and these things can change a lot with the neuroplasticity of attention. So with pendulation, with that technique that I just taught you, we can actually remap the somatosensory map of our own brains, which is super cool to me. And I've seen it happen in my clients, and I've seen it happen in myself. Not that I've looked at their somatosensory map, but that you can just feel the changes. So this brings us to the gate control theory. And we're not going to dive too deep into this, but there is some main points about this that I want you to understand. Again, we talked about how information from the body is detected by sensors on the nerves, right? So our nociceptors detect chemical changes, pressure, and heat. They send that information up the spinal cord into the brain. This next part is really interesting because it describes why a lot of us have a lot of the symptoms we do. When those signals get to the brain, they go through our limbic system. So they actually, the signals from the nociceptors, the chemical changes, pressure, and heat, get interpreted by our limbic system. So if you imagine you've been in pain every day for a year, that means every day for a year, your limbic system has been lit up and involved in your pain. Your limbic system is your emotional brain. It includes the amygdala. So that means things like fear and irritability and tiredness and depression are constantly lit up in the brain, constantly absorbed in this creation of pain. That's exhausting, and it can make us cry very easily. It can make us frustrated with other people, with ourselves. It can give us a lot of anxiety because that part of our brain is being affected. It also goes through the prefrontal cortex. So the prefrontal cortex is responsible for thinking and organizing and planning and what we call executive functions. This is why when you're in pain a lot, it's hard to think. It's hard to remember. It's hard to pay attention. It's hard to focus and plan, and it makes our cognitive functions harder. And of course, it goes through the somatosensory cortex as well. And there's many different parts of the brain it goes through, but those ones are important to me because they tell us why we're experiencing some of the feelings that we're feeling and some of the symptoms that we're feeling and how that can be associated with pain. Sometimes clients will come to me and they'll say, I'm having all these like memory and attention issues, and I would really like to do some cognitive rehab. And usually I'll kind of talk with them first and say, okay, do we need to do cognitive rehab, or are you in pain? Right? Because if you're in pain, your memory is not going to be as good, your attention's not going to be as good, your problem solving, et cetera, et cetera. And if we're doing cognitive rehab, that's not going to fix that because you're absorbed by the pain. But when we can reduce the sensitivity, we can reduce the pain, cognition usually gets better. So this is interesting. So that we talked about how it goes up from the nerves, but we haven't really talked about it going down from the brain. So our brain can actually influence the production of pain as well. So our emotions, if we are feeling, more fear about our pain, or we're feeling more anxious about it, or more sad, that's actually going to, basically, with the gate control theory, the idea is open up this gate in our spine by the downward regulation of the brain, and that's going to cause more pain. Same thing if we have negative thoughts about our pain, if we're constantly saying, I hate this, is the worst thing ever, I wish this wasn't happening, then that's also going to influence the production of pain. So our emotion and our thoughts physiologically change the perception of pain. Again, this doesn't mean that it's in your head or that you're creating it, but it does mean that we have more control over pain than we think. And this is really, really important to understand and to grasp. And this is why, for example, the pain experience from a bee sting is going to be a lot different for a beekeeper who's used to being stung every day versus someone who's afraid of bees. If pain was just like universal and everyone had a universal reaction to pain, then the exact same stimulus would cause the exact same response in every person, right? But if someone's a beekeeper and they get stung by a bee, it doesn't hurt that much, right? They're used to it. It might be it stings a little bit, but they're probably just like, whatever, it's fine. Why? Because their amygdala is quiet. They're saying, oh, it's fine. I'm not scared of this bee. This is a normal situation, right? Their prefrontal cortex is saying, oh yeah, I've had this happen before. It's okay. It's all good, right? So the interpretation and the emotional response changes the level of pain. It closes the gate in the spine that creates that pain. Now, someone who's afraid of bees, their amygdala is freaking out. Their frontal cortex has all these thoughts that are associated with being afraid of the bee, and that changes the perception of the sting, and maybe it hurts way more, right? So we have the exact same stimulus, completely different response based on how we're thinking about it and how we're feeling about it. And so that's part of the thing that we want to work on changing. One of the ways we can work on changing this is with SIMS and DIMS. So SIMS, it means safety in me, and DIMS means danger in me. Credible evidence of danger will turn our pain up, right? That guy with the nail through his boot, he had a lot of credible evidence of danger saying that he needed protection, right? So it's going to turn our pain up. Credible evidence of safety will turn our pain down. So again, that guy with the nail in his face, he thought he was safe because he didn't have any signs of safety. So when our DIMS outweigh our SIMS, when we have more evidence of danger than safety, there's going to be more pain. And if you've seen my lecture on nervous system regulation, we talked about triggers versus glimmers. This is very similar. So DIMS are kind of like triggers and SIMS are kind of like glimmers, the opposite of triggers, right? DIMS and SIMS could be things that you hear, see, smell, taste, touch, so your senses. So for example, you might feel like a little twinge in your muscle or hear some crepitus, some cracking of your joints, and then you're like, oh no, that's a danger signal, like I'm going to be in so much pain from that. That can create a DIM, right? But if we say, oh no, like cracking is normal, joints crack, that's what they do, that is, reassuring to your body and doesn't produce as much pain because your body doesn't think you need protection, basically. It can be things you do. So for example, going to an appointment might be a dim for you. You might feel like your doctor's going to say something you don't want to hear, or something like that could feel dangerous. Things you say, things you think and believe, like this will never get better, I'm a burden. Like, how can we replace that with something that feels safe, right? I can get better. I can have some control over this. I can do the things I want to do. Really, we want to think about replacing DIMs with SIMs. And if this feels a little muddy and confusing, there's lots of nice videos on YouTube that explain what DIMs and SIMs are, and exercises you can do online as well. Or you could take my 4-week chronic pain course where we go into this a little bit deeper. So the idea with pain is something called habituation. So if you think about it, we're reassigning meaning to this signal because our body's basically saying we're not safe and I need to protect myself. And what we want to say is that signal that I'm receiving doesn't mean I need to protect myself, is what we kind of need to rewire our brain to do. So some of the things that we habituate to in daily life is like living near a busy street. If you go and visit your friend's house who lives next to a train, you're going to sit down for dinner and you're going to hear that train and be like, that train is rattling the house and it's so loud. And your friend's like, oh, I didn't even notice. Because they've lived in that house for a while. They've gotten used to that train going by every hour and it doesn't affect them anymore. We also get used to strong smells. A good example of this is I used to volunteer at the SPCA. And when I walked in, it smelled like cats. It smelled like cat pee. It's gross, right? You walk in and it just like hits you like a wall. But after I was there for an hour working with the cats and hanging out with them, I didn't even smell it anymore, right? So we habituate. Something can be very offensive to the system, but as long as your nervous system is not interpreting it as danger anymore, it's not going to continue to pay attention to it. So basically, there's still some pain happening in my hip, but I'm not paying attention to it. I don't interpret it as danger anymore, and I don't feel like I need protection. So my body doesn't produce pain anymore. I can feel like sensations in there, but it doesn't feel like pain. It doesn't feel like danger. So we habituate to something because our mind deems the stimulus as not threatening or important to pay attention to. We'll have more difficulty habituating if something gains a meaning. So, for example, if we say, like, there's something horribly wrong and I know there is, and I just need a doctor to find the thing that's horribly wrong, and I just need someone to tell me what it is so I can fix it. That is telling the nervous system that something is really dangerous. And even if we did have something that was really dangerous, like a tumor, learning to say, okay, in this moment I am safe, and in this moment I am okay, in this moment I don't need this much protection, can help reduce that sensitivity. So this is the idea with pain. It's the idea with a lot of symptoms. This works really well for tinnitus too. How we talk about pain is really important. So a lot of my clients will tell me, it feels like I'm being stabbed. It feels like my head is in a vice grip. It feels like burning hot coals, searing pain. I'm definitely having a flare up, or just using the word pain a million times, which I have in this presentation, but it's a presentation about pain, so we would expect this. But our brains are very, very visual, super visual creatures, and they are really good at imagining things that we say. When we think about, something we have to do next week that's nerve-wracking, just thinking about it is enough to increase our heart rate, right? So we can have physiological changes in our tension, in our heart rate, in our digestion, just by visualizing something. So we really want to make our language about pain very objective. So we want to say, yeah, I'm in pain today. It's like a 5 out of 10. We don't want to say it feels like I'm being stabbed. We don't want to say it feels like I'm in a vice grip or whatever, because that's giving our brain something to just increase the pain with. I also, if you've ever worked with me, you'll know that I hate the word flare up. I don't think it's useful. I think it makes people like have a prescribed idea of what's going to happen. Because if you know for yourself that your flare up lasts 3 weeks and your pain is like 10 out of 10 every day, and you're having really bad migraines, and you need to take all this medication, that is basically you're setting yourself up for your brain to be like, okay, well, this is what's going to happen, and then sort of produce that scenario, right? So instead of saying I'm having a flare up, just be like, okay, well, there's more intense pain today. Today it's an 8 out of 10 instead of a 5 out of 10. And let's see what happens. Maybe tomorrow it's going to be better, right? We don't want to prescribe that we're going to be like this for 3 weeks. And it can also be helpful, instead of saying the word pain a lot, it can be really helpful to think of a different word. So pineapple, I don't know, whatever, something you come up with your friends, with your spouse, that you can use instead of pain, something to relate to other people that's what you're feeling without having to use the word a bunch. There's obviously going to be some big lifestyle factors that are going to influence our pain. Because pain is produced in our nervous system, sleep, mood, our diet, especially if there's an inflammatory component, our diet's going to be really important. And you can watch the presentation on neuroinflammation that we did. It's on the YouTube channel. Social engagement, super important. Engaging in pleasurable activities. Pleasure is the opposite of pain, right? So one of the first things to go for a lot of my clients when they're really suffering with something is enjoyment and fun and pleasure. And if we can seek to add fun and pleasure and enjoyment back into our lives, we can actually change our brains in very positive ways and reduce pain just by adding a little bit more pleasure, a little bit more fun. So when I give homework, I think it's important to have fun, to actually engage in things that are meaningful and fun. Think about that when you're thinking about activities to add into your day. Water intake, really important, right? Lubricating our joints and keeping things moving in the body. Meaningful activities, like I just said, and exercise. So we're going to talk a little bit about exercise. When we look at the pain cycle, we have pain, then we tend to avoid activity. A lot of times when we're in pain, we don't move. Then we have deconditioning, then we have pain with decreasing activity, and then we avoid even more. Then we have more pain. And then we have this other psychological cycle, like we were kind of talking about with the gate control theory: pain, anger, anxiety, fear, distress, decreased mood, depression, increased perception of pain because of the gate control theory, then more pain, right? So we get in these cycles. And how can we break these cycles? There's a few different ways. We can work on our emotions. We can work on regulating our nervous system and managing our emotions. That can help reduce pain a lot. And we're going to talk about that a lot in our self-management strategies next time. We can stop the pain for a bit. So with things like trigger point injections, injections of magnesium, Botox, things to just stop the pain for a bit can stop the pain cycle, or comforting things like heat, ice, that kind of stuff. Or we can move more. And a really good example of this is last February, I subluxed my shoulder. And I, at this point, had, I knew everything about the pain stuff. So I was like, okay, I'm going to treat myself like a client. And I talked to my physiotherapist and I was like, okay, which motion do I have to do that will resublux my shoulder? What's a not safe motion for me to do? And he told me that if I move my shoulder backwards, that I could resublux my shoulder. He said every other range of motion is safe. So I could move it forward, I could move it up, I could move it to the side. I could really move it every way except for backwards. But my body was trying to protect my shoulder from being re-injured. So my body gave me pain if I moved it forward, if I moved it to the side, or if I moved it up. My body was like, don't move it at all. And so what I had to do is be like, no, movement is good for me. This is safe. And I had to learn to move it forward and say, this is safe, this is safe, this is safe. I'm not going to re-injure myself. I don't need this protection. Thank you, body. I appreciate it, but I don't need this protection. This is safe. Reduce the amount of tension and just move it in that direction anyways. That helped it heal much, much faster and helped me avoid having chronic pain because I was able to move and heal the joint. If it's moving, there's a lot more blood flow, and that can really improve how we heal. So we have this saying in pain science, which is if you're thirsty, drink, if you're hungry, eat, and if you're in pain, you need to move. So movement is really important, and I know it's scary, and I know it's extra hard when you have, for example, like fibromyalgia, or you have like ME/CFS, where you have post-exertional malaise on top of pain. Then it becomes a little more complicated. You might need to work with a practitioner to actually come up with a schedule that works for you. But movement is very, very, very important. So I'm sorry, I keep sniffing and like coughing. I think I'm getting a little sick. So some exercise principles for chronic pain. First, you find your baseline. So it's the right amount of activity without increasing pain, being conservative. We want to find the edge of sensation. So if you've done yoga before, you might have heard this term. The edge is where, if we kind of go over the edge, we're going into like too much pain. Like it's not a good place to be. At the edge, there's a little bit of pain. There's for example, if you have a shoulder injury, your shoulder is the thing that hurts, and you're trying to reach your arm above your shoulder, you want to go to the point where you feel like you're starting to feel it, but you're not totally in the pain yet. And some of the ways that you can know this is that you're maintaining calm and even breathing. You can keep your body tension low. So when you're moving, it's going to be really important to notice if you have compensatory movements, or if your body tension, you're starting to tense up. And especially if you're getting a massage or something, same thing. If you're really tensing up around where they're pushing in, they're probably going too hard for it to be restorative, for especially for a chronic pain sort of presentation. If you can monitor your pain without reacting negatively, that's also a really good sign. Ease off if you're not feeling safe, you feel like you're going to pay for it later. Watch out for protective movements. We'll talk about those a little bit in just a minute. And then if you can't complete a movement, imagine yourself completing it. We talked about the power of the mind. This is a very powerful technique. Imagine yourself doing things without pain. Challenge yourself and build slowly. So you can increase by a few minutes or 5 to 10% more per week of what you're doing to move your body with the pain. And again, you might want to consult with a physiotherapist or something to say, what's safe? What is safe for me to do? And what would cause injury, right? So that you have a very realistic roadmap of the things that you can do and the things that you can't. Some ways that you can modify activities. So a lot of us have this like all or nothing thinking, where we're like, I got to do all the vacuuming or none of it, right? But you could vacuum for 5 minutes. You could vacuum once a week instead of 3 times a week. You could modify the intensity of an activity that you're doing, maybe changing out the vacuum for a lighter one. How you do the activity, you could vacuum a certain spot in your room while you're sitting down. You could take more breaks. You could vacuum for 10 minutes, take a break, vacuum for another 10 minutes, or you could just do like part of the floor instead of all of it, right? So we can think about, there's all these ways that we can modify activities, and we don't just want to think about it all or none. We do still want to move. Moving is very important. And when we're talking about pacing, we don't want to be in the green where we're not moving and not doing anything. Even if we're feeling, a pretty decent amount of pain, we still want to push just a little bit, not too much, and then break. Push a little bit, break. Push a little bit, break. We don't want to push all the way into significant pain where it's so much pain that we're crashing and we can't handle it for a long period of time. So we just go a little bit, we go into what I call our yellow zone, and then we take a nice break and we continue to work with our pain in that way. This helps increase the amount that we can do because we're telling our body that movement is safe again. We want to keep this in mind. Sore, but safe. It hurts, but it's safe. I'm not going to do more damage to my body. That's what's really important to kind of keep in mind, is finding the activity that for you in your personal situation, for whatever reason you have chronic pain, is actually safe for you to do. Some exercises that we recommend. So mindful-based slow movement that incorporates breathing. So Tai Chi, yoga, Pilates. If you haven't heard of Feldenkrais before, I love it. I think it's amazing. It's been really, really helpful for me and for a lot of my clients. So look that up, Google that. It's really slow, and it's slower than Tai Chi, yoga, or Pilates. So it is the slowest one, it is the easiest one, and it is very, very good for mind-body connection and for moving an area. You can just like wherever your pain is, you can just look like Feldenkrais for, you know, shoulder pain, or Feldenkrais for headaches, or whatever it is. Repetitive rhythmical movement, activities that you want to do. Don't just do something you don't want to do. Like rehab, again, should be pleasurable and fun. Get moving with friends or in a small group. It can be really helpful to have motivation, even if it's on FaceTime. Sometimes, if it's, I live in Nelson, BC, and it can snow a lot here, and sometimes you don't want to leave the house. Sometimes I'll just FaceTime a friend and we'll work out together via FaceTime. So that's something you can do. Use a positive distraction while you exercise, like music or being out in nature. And then give yourself a reward. We're very rewards-based creatures. So if you commit to working out, whatever your goal is, 3 times a week, or moving your body, doesn't have to be working out, moving your body, moving that part of your body, especially that has pain, a few times a week, give yourself a little treat at the end of the week. Make sure that, you're allowing your body and your brain to have that little treat for doing a good job. Ergonomics are really important when we're talking about movement. So being mindful of your posture throughout the day. Our phones are really bad for this. We're in so much more neck flexion than we should be, and that's a lot of pounds of pressure on the neck and the head. So be mindful of your posture. You could use a posture corrector if you want. So you can look up how to use those properly or talk to a physio about that. And just be mindful of how you're stacking your joints. And you can even look up videos on YouTube for correcting posture and be aware of that, because that's going to be an important part of making sure that things are weighted properly in the body. We want to watch out for guarding and pain behaviors. These are 2 things that in the literature have really shown to contribute to chronic pain. So muscle guarding is when we hold our muscles in a state of partial readiness to act. So that means, like, if I'm going to try and bend and get something off the floor, instead of just using the muscles that I need to do that, my whole back and all my thigh muscles and my glutes are just like all tense and preparing, like guarding that movement. We want to make sure that we're not doing that. We want to think about, when we're moving through the world, does this feel natural? Does it feel like I'm reaching for this thing on this high shelf and it feels natural? Or is my body really tense and I'm like tensing around it because I'm like anticipating the pain that it's going to cause? We want to move as far as we can within a natural movement. And if we can't move further, then we might need some kind of assistance to get something off the floor, for example, like a reacher. And pain behaviors are anything that show other people that we're in pain. So another thing that you could try doing for homework is limiting the amount of pain behaviors you show. So a pain behavior could be like, ow, ugh, or like squishing your face, or maybe using an expletive, or moaning, groaning. Like if every time you get up from the bed, you go, oh, that's going to reinforce to your body that that's a painful motion, and there's a feedback loop that happens. So if we can break that and we can just go, okay, I'm getting up, I'm safe, I'm good, I don't need this protection. You're kind of talking to yourself while you're doing that, and you're keeping your body tension low. That can reduce the amount of pain over time. So this is one of the last things we'll chat about, and then we'll get into questions. This is a nice little technique. It's called the myofascial release or muscle relaxing. Again, something you can look up online if you want to look up myofascial release. But basically what you do is just grab a tense muscle in the muscle belly. So you can usually find the muscle belly, it's like in the middle of the muscle. So it's usually where you're feeling the pain. So you hold a tense muscle. You can do it with your hands, or you can use a yoga block or a roller or a ball and put pressure into the middle of it. Not a lot of pressure, right? Everything that we do with pain, we want to approach it very gently, because we don't want to just scare it away, right? We don't want to make it more scared. If we're more scared, there's more pain. So gently into a part where it feels like, your pain is like just slightly increasing. Just a little gentle pressure into that muscle. We don't want to just dig into it, especially if you find that you're tensing around it or you're making a face. That's way too much pressure. So you hold it, you take a few deep breaths. just holding it in the one spot. Take a few deep breaths, talk to or coach the muscles. So you're saying, hey, it's okay, it's safe, let go. We don't need this much protection. It's okay, it's okay. And then we wait for it to have a release. And sometimes it takes like 2 or 3 minutes. Sometimes it takes a while for the muscle to be like, is this safe? I don't know. And then it will eventually, like you'll feel a little like, blah, like the muscle releasing. If it's a super tense muscle that's had a pattern of tension for a long time, it might take longer. It might take, a few weeks of doing this exercise for it to fully commit to wanting to release, but it's something to think about. We can think of our pain like a scared animal. It may need some time to trust that it's safe to let go. If you've been in pain for a long period of time, it may be really difficult for your nervous system to feel like it's okay to let go. Also, if your amygdala is really active, let's say you are a person who's had a lot of trauma, we might have to work through some of that trauma too, so that the amygdala isn't as active and it's not contributing to that production of pain. So working on the trauma, being very gentle with yourself, giving yourself time, like you treat your pain like it's a scared animal that you've adopted, that you need to train that it's safe to live here, that it's safe to be here, right? Because it's like a dog that's been beaten. It feels like it has to protect constantly. It's like barking and trying to bite other people, trying to protect, but really we need to teach it that it's safe. And safety is really what underlies everything to do with pain, because if our body believes we're safe, it doesn't need to produce pain because it doesn't need to protect us from anything. So increasing that sense of safety, incredibly important. Some resources. You can follow me on TikTok, Uplift Virtual Therapy, Instagram, my website. That's my email if you wanted to reach out. I do have a very long waiting list right now, so you can reach out and I can put you on that if you wanted to work with me one-on-one. We're also doing a 4-week intensive pain course, which is this exact same slides, but we're going through it very slowly and we're taking a lot of time to answer questions. And we're giving you homework, and it's meant to be a 4-week course to learn to actually manage your pain rather than me just kind of like, throwing this all up at you at this time. So you can find that in the emails from Bruno, and I'm going to put it on my website probably tomorrow as well. And there's a bunch of other things you can access through there as well. So let's open it up for questions. I'm just gonna stop sharing. And let's take a look at the Q&A. So the recordings are available on Dr. Arsenault's YouTube channel. I'm blanking on the name right now. We'll ask Dr. Arsenault when he's back.
Yeah, METV.
METV. There we go.
And there's a link directly on our website.
Perfect. Okay, then if you're dedicated to retraining new neural pathways for muscular endurance and control to stay out of pain, nerve compression, cervical postures, how long does it usually take on average to recorrect? So it depends how long you've been in pain for, and it depends how often throughout the day you're able to create those new neural pathways. Neuroplasticity works via a lot of repetition. That's what opens up the receptors in the brain to change. So sometimes it takes a lot of repetition, but I don't know, working on it for a few months we usually see some pretty significant changes. And honestly, sometimes in some of the studies where they were looking at like self-management strategies and education, sometimes even just receiving this education made a huge difference in people's pain responses. So yeah, it's possible that some of you might in the next week or so feel a little bit of a difference in pain already. How is the heightened sensitivity to pain integral to a diagnosis of central sensitization symptom detected and quantified? How is the heightened sensitivity to pain? So how is it detected and quantified? So it depends. People have different responses, but generally we know that there's sensitization if somebody has pain beyond 3 months. And some of the ways that it can be, like depending on the person, they might have very severe sensitization or less severe sensitization. For some people, even just touching an area lightly is super painful for them. So that could be a sign of sensitization. And there's like other signs, basically just having pain when we know that the underlying tissues have healed is a very good way to detect that, to know that that's kind of what's happening. And especially, I guess there's other things to think about as well, is like, is the pain very specific? So for example, if every single time you move your shoulder forward, you have a stabbing pain right here, that's a very specific pain and should probably be investigated more. There might be something underlying that's happening, right? But if it's like it kind of comes and goes throughout the day, you feel it more when you're stressed, you feel it more when you're like it's diffused throughout the body, or there's different parts that are in pain, or it's a bit more like diffuse of a pain, like a bit more achy, or just feels really uncomfortable in a lot of spots, that's a little bit more along the lines of sensitization. Do you know about the Pain Made Easy program? My insurance company is forcing me to start this month. I'm very unsure of it. This information sounds a lot more safe. I am not sure about the Pain Made Easy program. I would, because this person mentions they have ME/CFS, I would just be cautious of anything that's not informed of ME/CFS and pain management at the same time. Because graded exposure to activity is really bad for people with ME/CFS. The way that we need to do it with pain for people with ME/CFS is different than how we would do it for someone who doesn't have it. So I would just really maybe even reach out to the people who do that program and ask if people with ME/CFS take that program and if they take that into account. Oh, someone said they didn't see the slideshow, only me. Hopefully you guys could see the slideshow throughout that. What about times where there's all of a sudden intense pain? Wouldn't that suggest that there could be something really wrong, possibly, and saying you're safe and you're okay might not be the best thing to do in that case? So yeah, in the beginning, we talked about reasons to not do this. And one of them is sudden or unexpected or very intense pain. If something is really intense and it's new, talk to a doctor about it for sure. We want to make sure that we're being safe and not ignoring something that could be important, right? So that first slide that we talked about, I can share it again. So yeah, it was like one of the very first slides. Here are the reasons to see a doctor. So you can take a look at that again if you want. Okay, I'm struggling with some of these concepts. For example, is CS, sensor sensitivity, a physiological thing that can be seen? Like, do the sensors on the nerves change? So it's not necessarily that you could, I mean, I think in imaging, you might be able to see it. I'm not actually sure. I've never looked into that, but because there's all this science saying that the receptors have changed and become more sensitive, I'm assuming they've done research where they've looked at it. And we can definitely see the changes in the homunculus. So, with the homunculus, if you're pressing on one part, you can feel it in that part of the body. So they've done research where they've kind of pressed in different parts for different reasons with neuroplasticity. So it could be something we would say is good, like it could be someone playing the piano and then their finger sensation gets more, or it could be with pain. So we do see changes in the homunculus and in the nerves, in the nerve sensors. What if pain levels are constant and unaffected by ups and downs in depression, fear, or distraction? Is it a different kind of pain? I think it'd be important for me to understand a little bit about what your diagnosis is to answer that question. Do you have advice for people with trauma, PTSD, who may not have success with typical neuroplasticity techniques? Trauma can obviously interfere with habituation and is resistant to self-talk. Yeah, so for people with PTSD or trauma, I recommend checking out my nervous system regulation PowerPoint. It's on the ME/TV, Dr. Arsenault's YouTube channel. So that has a lot of like trauma safe practices for neuroplasticity, because like you're saying, yeah, self-talk doesn't necessarily work. There's a lot of techniques that we have to do that really soothe the amygdala directly rather than just the self-talk. I'm just going to go back to the contact slide in case people didn't get that. Sorry for the, oops. There we go. How does this apply to ME and how to improve pain and exercise within the envelope when you've been told to rest? So even with ME, you're not supposed to rest all the time, right? We do want to push into our yellow zones, and we do want to do activities with pacing within your energy envelope. So you can apply the same pacing principles that you've learned for your ME to pain. And just kind of when you have ME on top of pain, it's really important to think about how movement can impact both. And when we're saying movement, it doesn't have to be like you're going out for a walk. It could be literally that you're doing, like, for example, Feldenkrais, where you're just lifting and lowering, lifting and lowering a shoulder over and over and over again, which probably wouldn't cause post-exertional malaise. So there are ways that we can move with our body and with our pain that might not cause PEM. Does any of this advice change for people who deal with hypermobility? So yeah, hypermobility or Ehlers-Danlos, again, you just want to play within your limits, and you might have different limits based on your mobility. So you know how we were talking about the Twin Peaks model and the protection from pain versus the tissue tolerance. With hypermobility, you might have the protection from pain might be a little closer to the tissue tolerance. So you just have to pay attention to that a little bit more. It's not cause for alarm. It just means that you have to connect with your body and get to know your body a little bit better. Someone said that they found an ice migraine relief cap on Amazon. They find it really helpful. Yeah, I just read a study last week about putting ice on your head and putting your feet in hot water at the same time. And people who did it every day for 20 days found a very significant relief in migraines and in headaches. So I thought that was really interesting because it's pulling the blood away from the head. Will you offer the pain course again? I might. Yeah, so I did a nervous system regulation course, rewiring the nervous system, and this pain course, and I'm pretty sure I'll do them again in the spring. It just depends on kind of scheduling stuff. Instead of a flare-up, what is a term I can use to convey to teachers, accommodation staff in the academic setting to request accommodations in school? So you can just say that my pain is more intense today, and sometimes when my pain is more intense, it might last a little while. That kind of language, right? If you're trying to convey it to someone else for accommodations. And usually within an accommodation letter, so a letter that kind of specifies what we're doing for accommodations, I would have set out, like, you know, if I say that my pain has increased to this, then it might mean that I'm off for this long or whatever it is. But when we're conveying it to other people, it can be a little trickier than when we're saying it to ourselves, for sure. Someone said, any plan to do a session on trauma? So we've done a few on rewiring the nervous system, on neuroinflammation and stuff like that. So just check out the METV channel. There's quite a few there that are related to trauma. I could do a PTSD specific one if that's needed. So someone says, special tips for bladder pain that tends to cause unwanted voiding. So again, with any of the pain, we're going to want to use these techniques. And then when we do the next presentation on pain, we're going to also be talking about self-management techniques. So using some of the techniques that I brought up in this, and then using the self-management techniques. And again, if it feels like too much to absorb, you can join the course. I have more pain with rest than movement. The last exercise is useful. Is there anything else that might help someone who moves a lot but avoids rest? I think the kind of movement that you're doing is really important. So if you can move, and that's good, we want to do movements that connect the mind and the body. So like I talked about before with the Tai Chi, the Feldenkrais, the yoga, dance, movement therapy can be really powerful for a lot of people. So if movement feels good, then really hone in on that and do movement experiences that also incorporate mind-body connection, because we lose a lot of our mind-body connection or interoception when we are in pain for a long period of time. So doing those movement-based practices can be really helpful. So how does fibro relate to this and sensitization? So fibro is a disorder of sensitization in general. And whenever we can reduce the sensation, when we can reduce the activity in the amygdala, so with nervous system regulation techniques and stuff like that, when we can reduce inflammation, we can reduce some of the pain associated with fibro. And fibro can often be connected to that, especially a lot of people with fibro might have trauma. It's not necessary for having fibromyalgia. It can also be related to what we call the cell danger response, which is like if the body has ever encountered like a virus or mold or things like that, or psychological trauma, physical trauma, that can be a precursor to fibromyalgia. But fibromyalgia really is that sensitivity of the amygdala and the nervous system. So by using these techniques, fibromyalgia is like one of the main things that can help a lot. Sorry, I'm just reading this question. It's a little longer. Okay. Do I know someone who's good for TMJ issues? It depends where you are. But I'm not really, I don't know if I know of anyone specific. Dr. Arsenault, do you know of any good physios for TMJ or doctors?
No, usually I refer people for trigger point injections for TMJ.
Yeah. I also recently have been informed about trigger injections combined with magnesium, which is, my clients are getting really good results from that, because it's like a mild sedative for the muscle. So that's a nice combination. Oh yeah, and Dr. Arsenault, do you have anything else to say about the connection with fibromyalgia to this kind of education?
Fibromyalgia is the classic central sensitivity syndrome. And like you said, the danger cell response, fibromyalgia can be triggered by physical injury, and the pain persists beyond the injury. It can be the result of chronic pain in other areas, so just the pain becomes widespread, but it can also be triggered by psychological and infectious triggers.
Yeah. Yeah, thank you for that. Okay, so this person says, I appreciate what you said about using objective words, but the problem that they find is that the medical system is programmed to respond to patients with much more when they use descriptive terms to explain pain. So when I had been objective at the ER, calling pain a 7, I never got any tests or diagnosis. Now I have been diagnosed with 11 different things since being part of this clinic. Yeah. So suggestions on how to both get taken seriously, but also not saturate yourself with thoughts on how bad pain is. I would say I agree. And I know it's a problem with our medical system that, the squeaky wheel gets the grease, right? If we're louder and we are more descriptive, then sometimes we get more treatment. So in those settings, it might be appropriate to advocate for yourself by using more descriptive language in those moments so that you can really get across what you're feeling. But when you're talking to your friends, when you're talking to your family, when you're talking to yourself, try to avoid those words. But I agree that sometimes we might have to kind of get the attention that we need. Or we find a great doctor that will listen to us, like Dr. Arsenault. What if you've never had imaging done and you don't feel 100% sure there's nothing wrong physically? I have chronic neck back pain and fibromyalgia for years and have never been told to get imaging. I feel like just wondering about that prevents me from convincing myself that I'm safe. What I would recommend is finding a physiotherapist who is trained in pain, so they don't tell you a bunch of words that are really scary. Sometimes on imaging, people can have like degenerative disorders and not have any pain. Like someone's spine could be very much degenerating and they don't have pain, or someone's spine could be degenerating, they have a lot of pain. So imaging isn't always the most helpful, but if there is something really wrong, it can be helpful to make sure that it's not. But a physiotherapist, what they can do is they can kind of look at your range of motion, feel around and see if it might be necessary to like get your doctor to refer you for imaging. A doctor, a really good trained doctor, can also do that, kind of give you a bit of a physical exam and make sure. So yeah, checking with your doctor and your physio is never a bad idea if you have an idea that something is wrong. But we also want to keep in mind that most things are going to heal within, 6 to 8 weeks. We're going to see most bones, joints, ligaments healing. So there are some other things that can last a bit longer, and especially like ligament instability and stuff like that. But physios and doctors will be able to rule that stuff out. So definitely good for peace of mind, I think. When you wake up in the middle of the night with pain, how do you deal with the pain? So it's next time we're going to be getting into a bunch of self-management techniques for how to deal with the pain. This time, you can think about the pendulation exercise. You can think about the muscle releasing. You can think about really gentle movement to do, or throwing on maybe like a meditation or something in the middle of the night to distract you. But next time I'm going to give you a bunch of resources on how to manage pain, the self-management techniques. That's what the next session is about. Does niacin help inflammations and pains? Thoughts on niacin, Dr. Arsenault?
Not that I've ever heard of.
Yeah, I haven't heard of that either. PTSD lecture and an ADHD brain fog lecture. Dr. Arsenault will chat about that. I can definitely talk about those two things. So this person said, my pain has been reduced just listening to you and coaching myself to say I'm safe. Can pain be resolved that quickly? It took about an hour. Yeah, like I said, a lot of people receive this education and within a week they feel better, because not because I'm a magical, practitioner or something, but because this is science-based and an evidence-based way of treating pain. The education that you've just received is a very good treatment for pain that's more efficacious than a lot of pain treatments out there. So yeah, having received this education can definitely reduce pain. They do inject magnesium in trigger point injections. Yeah, some doctors will do it, some doctors don't, but yeah. Tai Chi video. I don't know if I have a specific recommendation, but I always go to YouTube for stuff like that, and YouTube has so many resources that are great. So check that out. And choose one that's a good length. Like you could probably look up like Tai Chi 5 minutes or 20 minutes, whatever you want to do. Someone's asking about suggestions for free online courses. I don't know. Email me. The person who asked about the free online options, send me an email and I'll see if I can find some resources for you. My email's right there. The Pain BC website, someone asked what my thoughts are about it. I think it's great. I think it's a really good resource. Pain BC actually is a good place for a lot of free resources, and they have free pain coaches that you can access if your doctor signs you up for them. It'll be a lot of this similar education, but it's really helpful to have a coach that can go through, and they're free. And then they also have a really good podcast. The Pain BC podcast is really good. And also, if you look up chronic pain in Spotify, there's a lot of good podcasts about it too, which I find is a really nice way to absorb this information. Okay, we have 10 more minutes. Does anyone else have other questions about this? You can ask whatever you want. No question is a bad question. Okay.
If we run out of questions, we can end early today. And then we'll see you back in 2 weeks to do part 2 of this, the self-management techniques.
Okay. Oh, Andrea said they have a question. And Vicky said, can this work with other sensations like tremors, buzzing? Yeah, totally. Habituation can work for a lot of things. I've also used it for clients with tinnitus and things like that. This person saying I have pain that comes for 2 weeks, very strong. Not sure how to handle that. It's hard to know without knowing a little bit more about your pain, but I think it'd be a good idea to get assessed by a doctor or a physiotherapist and see what they think. And then next week or 2 weeks from now, we're going to be talking about what to do when the pain is like very strong and some techniques for that as well. When having fatigue, should I continue to exercise or rest until feeling better? So we want to play with our green, yellow, and red zones. If you have a little bit of fatigue, but it's manageable, then that's okay. We just want to rest a bit, like maybe, 2 minutes, 3 minutes, 4 minutes of rest. But if you are starting to go towards your red, we don't ever want to go into the red. But if you're starting to go towards your red zone where there's a lot of symptoms, a lot of fatigue, then we don't want to keep pushing. A very easy way to make the most sense of it is just write down your level of fatigue before you start an exercise. So let's say you start at like 3 out of 10. Then keep track throughout the exercise. If you go up 2 points, it's time to rest. And if you can't get those symptoms back down, you can't get that fatigue back down those 2 points, then it's time to break for the evening. So the 2-point system is really good when we're thinking about how to pace with fatigue. So sometimes, yeah, especially, so this person said I had trigger point injections and they triggered nerve pain for a week. Super common because especially if the area is sensitized, then those nerves have just received an injection. Not the nerves, but the muscle has just received an injection, and then your nociceptors are like, what the heck is going on? I need to protect this area. So if you imagine even touching the area is sensitive, then some people have a big reaction to the trigger points after, but that usually settles, and then it's a break in the pain cycle like we talked about earlier. And then being bedridden with severe ME/CFS, what do you recommend for types of exercise to keep fatigue at a minimum? Feldenkrais is a really good one because you can do that from bed. Yin yoga, restorative yoga, those things you can do from bed. So you can think about exercises that you can do either just like kind of sitting up in bed or laying down in bed, and that might be helpful to just get the body used to a little bit of movement. So yeah, another person was saying they have a lot of pain with trigger point injections. I know, I've had them too. They're really painful. I'm sorry that you're in pain. And what can you do? So try the pendulation exercise, notice the pain, and then try to notice something else that feels neutral or pleasant in your body. And you can even introduce a different sensation. So for example, you could put some heat, not on the area, but you could like put some heat, for example, on your legs, and then feel that nice sensation on the legs and try to really pay attention to that. And if that's too much, you can distract yourself. Like in this, immediate surge of pain, you could like watch a funny movie or something like that. So this person says, my employer is asking for a letter explaining why I need to work from home. How much should I disclose about my illness? That's a really personal decision when you have chronic fatigue, how much you're going to disclose. So I think it's important for you to think about it, maybe talk about it with a trusted friend, or if you have a therapist, you can discuss and think about what are the pros and cons, right? What are the pros of me disclosing this, and how much do they actually need to know? Versus how much can I actually be vague with this and say, I have a health condition that impacts my ability, or perhaps even getting your doctor to write you a note can be a bit of a stronger thing than you wording it, just so that they can feel like the authority from the doctor sort of on that situation. But yeah, it's a very personal decision whether you're going to disclose or not, and there's no right or wrong answer depending on the person and depending on your job and how they'll receive it. When there's inflammation and swelling as well as pain, should we still attempt the system? Still push. So we're not pushing too much, right? We're just pushing very gently, just kind of moving into it gently. But inflammation and swelling, so swelling is something we want to kind of monitor. It depends what your condition is. Like if you have CPRS versus do you have arthritis, then there's going to be different managing techniques. But you want to work within your 2 points. So, and work within your yellow, red, and green zones and really figure out your personal system for pacing. If you push, so to speak, and then you crash, that's too much for your personal system. And if there's new inflammation and swelling, then you want to make sure that you get that assessed, because swelling is sometimes associated with something broken or something. So you want to make sure that it's not an acute injury. What is important to make very clear is that we're not using this sort of system in an acute injury. This is for chronic pain, right? For pain that's lasted longer than 3 months. Going to be a little different when we're relating to acute. We can use a lot of these strategies, sure. We can still tell the body it's safe. And like I explained with my shoulder injury, how there was certain movements I could do that were safe, but we want to make sure that we're not, that we're not just approaching acute pain in the same way. On top of fiber, I broke my knee and it's longer than 3 months. It's still sore, but there is a spot sore to the touch and leg collapses sometimes. How do I tell if I'm safe? I would get assessed by a physio. Just make sure there's nothing else going on underneath, a physio or a doctor. Why would pain be increased after being in a float tank where pain disappears? That's an interesting question. Maybe because you had like a bit of a relief and your body was super relaxed, and then coming out, maybe your body became more tense and cold and whatever it is. I'm not sure. That's an interesting question. Okay, one more. Can your family physician perform trigger injections? And I have been doing guided hypnosis and working towards self-hypnosis soon. I do this during bedtime, but I'm curious if you have any opinions on alternative times during the day. Some physicians will perform trigger injections. It just depends on what their training is, but oftentimes it's done in a pain clinic setting. And I love guided hypnosis. I offer hypnosis to people. I think hypnosis is a really powerful tool. You can use it any time of day. Sometimes it makes you a little more drowsy. What if the fatigue is potentially due to depression? Should you try to test your boundaries in hopes of gaining momentum when you can't tell if you really are in your yellow-green zone, if it's fatigue? So fatigue and depression are sort of like they're two sides of the same coin. Sometimes we can feel really fatigued and it's what we call the freeze response, and that can either come with emotions or it could not come with emotions. But we want to take all of our symptoms as points on that 2-point system. So emotional symptoms count. So if you're noticing your depression goes up with your movement, that's another thing to keep in mind with pacing. And don't worry about the writing of the questions. It's okay. All right, great. Well, it's about to turn 4:30. So thank you everyone for paying attention and for being here and for answering or asking your questions. I'm happy to be here and help you. Again, there's my contact info, and you can see the emails to Bruno to sign up for the 4-week course. Again, where we go through the same material, but much slower with homework and kind of pacing through it in a different way. All right. Thank you so much.
Thanks very much, Zara, and we'll see you in 2 weeks.
Sounds good.
Bye-bye.
Take care.